the outset, I would like to thank the organizers of Summer Pedicon for having me here and for all you to be here in a post-lunch session. So this happened a while back when one of my friends was visiting from the US and he saw this board on the road. It said, lovely rice, stone free. And he was surprised and asked me, do you have stone full rice also? So this is the expression that we usually get when we tell parents or someone that there can be stones in kids also. So really, we know that in adults it's a very common disease. 10 to 15% of adults have stones, but it's supposed to be very rare in children. The prevalence is around 1 to 5% in developed countries, but in something known as Afro-Asian stone belt, it is an endemic disease where 10 to 15% of kids have stones. It's probably increasing in incidence, that's why we get to see them more often. Okay, so we know that stones can occur in children, but why? It's mainly related to urinary tract malformations and infections. And in our place, it's more related to the environmental conditions where higher ambient temperature, dry climates and prevalence is proportionate to temperature as well as the sunlight index. In North India, along with Florida in US and Ukraine, they have absence of Oxalobacter formigenes, which is a bacteria which is normally found in all our guts and which metabolizes oxalate. Decreased fluid intake is a very common reason. Dietary habits with very high protein intake, high salt intake, low vegetables, low potassium, all will contribute to stone formation. In addition to this, we have other risk factors like supplemental calcium, dietary oxalate, sucrose, fructose, sugar sweetened soda. You can all relate to this to our current food habits of children. The DASH diet, which is a Mediterranean diet, it has a lower risk of nephrolithiasis. Caffeinated drinks are supposed to have a preventive effect, but of course they are not recommended for children. In addition to all this, preterm birth, low birth weight, NICU admissions, presence of inflammatory bowel disease, prolonged immobilization, overweight and obesity, neurological diseases which can be associated with decreased fluid intake, drugs like diuretics, anticonvulsants, antibiotics, and excessive intake of vitamin D can all be associated with stones. I would especially like to stress on this vitamin D because we live in an era of obligatory vitamin D supplementation for our infants, and as a nephrologist we do come across many kids, many infants with stones and or nephrocalcinosis, and the reason is just very high vitamin D levels, and we just stop them and ultimately they disappear. Salt is another thing that I would like to stress because it's the most important reason why the kidney stones are increasing in children. When you see healthy children more than 2 years, the recommended dietary intake is less than 2.3 grams, which is much more than what all our kids are taking now. I mentioned about the Afro-Asian stone belt, which is the endemic stone belt. The thing is, these countries, they have a higher incidence of bladder stones. And whereas the developed countries, they have stones localized predominantly in the kidney as well as the ureter, and it is composed of calcium oxalate and calcium phosphate. Whereas in the low-income countries, this basically happens because of very low protein intake. The stones are basically uric acid or ammonium. But Kerala, we don't find this bladder stones. I mean, if we see the stones are mostly coming from the kidney and then reaching the bladder. We usually follow the pattern of developed countries. Because of lack of time, I wouldn't go to the pathogenesis part, but basically it's because of increased excretion of solutes, low urinary citrate, abnormal pH. The urinary pH is a strange thing. If the pH is less than 6, it will increase the solubility of calcium phosphate. If it is between 6 to 7, it increases the solubility of uric acid. And if it is more than 7.4, it increases the solubility of cysteine. So basically you need to know what the type of stone the child is having to make a prescription of whether to alkalinize the urine or not. In addition to this, we have inhibitors of stone formation like magnesium, citrate, pyrophosphate, uropondine, nephrocalcin, etc. The reason why stones occur can be broadly divided into metabolic abnormalities like hypercalciuria, hyperoxaluria, hyperuricosuriia, urinary abnormalities and infections, and drugs. And also, we see most of the cases are idiopathic. The metabolic abnormalities are important because they are associated with a very high recurrence rates. And in adults, the recurrence rate can be as high as 40% within 5 years. And of this, the most important one that we see is hyperoxaluria. In addition to this, we can have several inherited disorders, especially hyperoxalurias and cysteinurias. And interestingly, most of them can cause chronic kidney disease also. So how do they present to us? They can present with, mostly they present as recurrent flank pain or repeated attacks of UTI. And around 10% presence is incidentally detected in asymptomatic patients, or they get an ultrasound done for something else and it reveals stones. They can also present as gross hematuria, microscopic hematuria, sometimes as graveluria or lithiuria, sometimes as unexplained sterile pyuria, and also as lower urinary tract symptoms. Sometimes they are very silent and present in obstructive uropathy. In younger children, they can just present with nausea, vomiting and irritability and failure to thrive. So how do we diagnose? We look at the history, physical examination, investigations and other workup. In history, the family history is very important. Like Geeta Madam said, for migraine, it is very important for stones also. Because depending upon the basic illness, it can follow an autosomal dominant, recessive or X-linked pattern. Look at drug history, dietary history, the fluids that the child is normally taking, history of polyuria, which can indicate an underlying disease like renal tubular acidosis, chronic diarrhea, inflammatory bowel disease, which can all be associated with oxalate stones, history of recurrent UTI, hearing and visual abnormalities again are associated with some renal tubular acidosis and seizures. Physical examination, malnutrition, presence of rickets. Rickets is associated with renal tubular acidosis. Gouty arthritis is associated with hyperuricemia, hearing and vision. Investigation should start from urine. The urine analysis can show stones, urinary pH and specific gravity, urinary culture to rule out UTI, and spot evaluation, the assessment. The blood examination will involve an RFT, electrolytes, the pH, serum bicarbonate, calcium, phosphorus, uric acid, magnesium. Imaging should include plain X-ray, ultrasound, and depending upon the case, IVP or CT. There are other specialized investigations. If you can get the stone, you can do a stone analysis, and vitamin D, PTH levels, blood oxalate, and vitamin B6 wherever required. So these are the normal crystals that we can find in urine. Depending upon the shape of the crystals, and you can actually maybe you can get a clue about the type of stones. You can do a sodium-potassium ratio in a urine sample. You can do a spot calcium-creatinine ratio, and hypercalciuria can be diagnosed by a spot calcium-creatinine ratio. And if it is elevated, we can do a 24-hour urine estimation for calcium. The plain X-ray we all know will show only radio-opaque stones. It will not show even small stones. Some of the stones which are radio-opaque are calcium oxalate and calcium phosphate. The magnesium stones, magnesium ammonium phosphate, apatite and cystine stones are poor radio-opaque, but they might be seen. But uric acid, xanthine, 2H-dihydroadenine and drug stones are always radiolucent and cannot be picked up by the X-ray. Ultrasound is the usual imaging modality that we follow first, but it can image only the kidney and the proximal ureter, and it is less sensitive for detecting stones less than 3 millimeters. IVP is not routinely done. Helical CT is then reserved for when the ultrasound is non-diagnostic and still we suspect stones. The advantage is we do not need contrast to pick up stones, and can also image the distal ureter. Metabolic workup is done when we have a family history of stones, or when there is nephrocalcinosis, in which it is a renal parenchyma which has calcium deposits, when the urine is persistently sterile but shows pyuria and has recurrent stone formation, or presence of malnutrition, polyuria and rickets, where you think that there is an underlying disease like renal tubular acidosis. So 24-hour urine collections are preferred. We can do a spot urine solute by creatinine ratio as a screening test. The important thing is, if there is a history of stone passing, you should wait at least 6 weeks before you do a metabolic workup. And it's said that ideally you have to repeat the test 3 weeks, which is not practically possible for our cases, so usually we do it only once. And during a UTA, you should always refrain from doing a 24-hour urine workup. Stone analysis, if you can get a stone, it's very good, because you can just give it for analysis and they will tell you which type of stone it is, and your treatment is easier. Genetics testing is now very much available, and it is usually done for when there is history of family history of stones, when there are recurrent stones, or when the etiology is unclear, especially in a very small child. There are different genes which have been implicated. So how do we manage? First is pain relief by using NSAID is ideally avoided. As a nephrologist, I would never write an NSAID prescription. Paracetamol is the one that we try to use, or like if the pain is very severe, opioids. Acute decompression may be required if the patient is having an anuric AK or you have a UTI with obstruction. Surgical management is basically shockwave lithotripsy, but it is not very possible in less than 6 years of child. So basically they do a ureteroscopy or a percutaneous nephrolithotomy. We are more interested in the medical interventions, so we want to increase the fluid intake to more than 1.5 to 2 liter per 1.73 meters square per day. Dietary modifications will depend on the type of stones. We want to restrict the calcium intake to the recommended daily allowance. We want to reduce oxalate-rich foods, especially if the patient has hyperoxaluria. Reduce the salt intake to less than 2.3 grams. Increase potassium to more than 120 milliequivalents per day. That means basically increasing the fruits intake. Increase citrate and fluid intake. And reduction in animal protein, even though it's recommended for adults, is not recommended for a growing child. A diet rich in vegetables will be a good source for citrate and potassium. And depending upon the type of stones, we can add drugs like potassium citrate for hypercalciuria, hypocitraturia, thiazides for hypercalciuria, then magnesium when there is hypomagnesiuria, pyridoxine for hyperoxaluria, etc. Just two conditions that I want to highlight. One is hypercalciuria. Idiopathic hypercalciuria is a relatively common condition. Basically, we have more than 4 milligram per kilogram per day urinary calcium excretion, or we can use the spot urine calcium creatinine ratio in an older child, say more than 3 years, more than 0.2 would be a useful cutoff. The treatment we have just discussed, basically you use potassium citrate and hydrochlorothiazide. Hyperoxaluria is also a relatively common condition. There are different types of hyperoxalurias. One is the primary oxaluria, which is genetic, which is a very bad disease to have, and it always progresses to end-stage kidney disease. What we mostly see is secondary hyperoxaluria, which is either due to increased intake of oxalates or excessive reabsorption because of alteration in microflora. Again, we can use spot cutoffs or 24-hour urine, that is more than 0.7 milligram per kilogram per day is supposed to be hyperoxaluria. So treatment is basically to reduce the urinary oxalate. So we advise a diet which is like having less oxalate, basically to avoid all leafy vegetables, all vegetables which grow under the ground, chocolate, tea and coffee. The next is to use potassium citrate, again to alkalinize the urine. Orthophosphate and magnesium are inhibitors of oxalate stone formation. Pyridoxine is actually the only pharmacological drug which has been used to reduce oxalate excretion. We can also use the oxalate eating bacteria, which is Oxalobacter formigens. So basically I want to emphasize that kidney stones are probably increasing in children and the salt intake is a likely culprit. Even a single stone in a child needs evaluation because it could indicate an underlying metabolic abnormality. Medical management thankfully is highly effective in children. So thank you and wish you all a stone-free best quality life.
Thank you, ma'am. It was a nice presentation and informative talk for you about stones in kids. Any questions from the audience? We can go to the next section.
Thank you.
The next topic is syncope in children. We got an eminent speaker, Dr. Edwin Francis, Director and Senior Consultant Pediatric Cardiologist, Aster Medicity, Kochi. Over to you, sir.